Welcome, everybody. We have about 8 or so people in the room here in Edmonton. And like I said, I expect more people to kind of come on as time goes on here. So I just wanted to do kind of a short introduction to welcome everybody here. You know, the goal of this is to be kind of more Canadian-wide, more inclusive, have more cases across different disciplines, and kind of share our experience, share our kind of different wisdom from, building programs to different techniques in ultrasound to innovation. So I think it's great to have new speakers every time and really highlight different areas of ultrasound that's being used. So that's basically it. So from 12:05 to 12:25, it'll be Leon. And Leon is a local intensivist here who completed an ultrasound fellowship, has a wealth of experience. He's also the kind of foremost podcaster in critical care with his Critical Care Commute podcast, which is pretty exciting, I would say, a local Edmonton thing. So that's fantastic. And then we have Alberto Goffi presenting from 12:25 to 12:45. Alberto is well known in ultrasound education circles and ventilation circles, very, very accomplished intensivist, educator, researcher from Toronto, who has I think more things to say than all of us combined on the topic of ultrasound. So welcome to bring him here. And of course, I'm Brian. I'm a intensivist educator researcher in Edmonton at U of A, and with a focus on ultrasound education and research innovation as well. So let's get started here. I'll stop sharing and we'll let Leon go first.
Okay, sounds great. So yeah, this presentation that I'm about to give is really just based on a case. Again, it's a case that sort of outlines how POCUS served to really accelerate the patient through the system, to get to a speedy diagnosis, to get to speedy referral and really speedy treatment. But it does have a bit of a twist, and I really hope that there's a lot of internists on the line here, because it's time to nerd out a little bit. You'll notice that this case is also typical of point of care ultrasound. None of my videos would be comprehensive, and certainly once POCUS answered the question, we could move on fairly quick here. So the title, of course, is Heart Fever, the Herald of Badness. And it really is around a case that I had. Oh shoot, just give me 1 second. There we go. Of a 34-year-old male patient that came from his local emergency room with really only constitutional symptoms and maybe some symptoms that could be explained by heart failure. But essentially febrile illness for about a month, and on his acute presentation, he had orthostasis, he had, a period of fatigue and just a loss of appetite. And with at his emergency room, he explained symptoms of fever, chills, but not really anything to hang your hat on. The sending physician was a little bit concerned after his examination that, some of these findings were in keeping with heart failure, and the patient developed shock while he was in his unit with a low blood pressure and not really doing too well. So he phoned me and we accepted this patient straight into the intensive care unit. Of course, my thinking was at that time, with a month of febrile illness and now you're shocky, sepsis first and foremost, but were we dealing with perhaps infective endocarditis or something at that point, is what my thinking was. So when he arrived, I almost immediately put a probe on him, and here you can see the parasternal long axis views. Not the world's best views, but certainly without the color Doppler, nothing really super concerning. I think if you use your imagination a little bit, perhaps his EF is a little bit down if you consider the EPSS there. But otherwise, his valves on 2D, apart from the one cusp that you can't see, is really not looking too bad. That changes somewhat when you look at the color Doppler, because that then gives us the suggestion of a bit of mitral regurg that is ongoing there. In this view, certainly saying anything about how severe it is would would be difficult, and this was unfortunately the best view I could get at that time. So I immediately proceeded to look at his short axis views, which was unfortunately horrible and not super helpful. But I did manage to get quite a good apical 4-chamber view here. And as you can see, again, his EF is perhaps a little bit down in this 4-chamber. And looking at the 2D morphology of the valves, if you use your imagination, maybe it looks a bit thickened, that mitral valve, but otherwise you have fairly good RV function. TAPSE seems fine. Apical 5-chamber view, before I put color on, changed things a little bit. And I'm not sure how it's displaying on your side, but I want to draw your attention to that goober in the LV. There's certainly something floating there that doesn't look completely normal. It certainly shouldn't be there, let's put it that way. And then putting color Doppler on changes the severity. And suddenly we're dealing with at least a moderate to perhaps severe mitral regurgitation here. Based on the clinical findings and the patient being in shock at this time, certainly was concerned that the MR has got a lot to do with his current presentation. I did not seek any pulmonic Dopplers at this point, but really tried to focus a little bit more on what was going on at the valvular level, and then certainly tried to identify what's going on in the LV itself. With continuous wave Doppler, the signal certainly, I think, supports at least a moderate mitral regurgitation at this point. So I tried to really hone in on what this mass could be, this thing floating in the LV. So that you can see it, and again, I hope that it displays well on your side. Is this visible for you guys, Brian? Can you see it well?
Very visible.
Yeah. So certainly not normal, And so then, say again?
I wouldn't think so.
No, Brian, and even for myself, yeah, I could see it. Going back to the 5-chamber view, it was clear that mitral regurg was affecting his cardiac output to a certain extent, in that our LVOT VTI was a mere 11.6. And his cardiac output was calculated, and I believe it was 1.8 liters a minute, if I remember correctly. Sorry, for some reason I didn't include that slide there. So then proceeded to do a apical sort of 3-chamber view here, sort of in and out of a 2-chamber, 3-chamber. And again, that mass can be demonstrated, and it seems to be, I don't know if it's pedunculated or at least adhered to the anterior wall of the valve there. I'm sorry, of the endocardium. So, given that we had moderate to severe MR, something floating around in the LV, I increasingly, realized that I'm probably going to need an expert that works with the pump. And so that's precisely what we did. And cardiology was very happy to help us. And I must really commend them for really coming to the party always at our site. It's pretty cool that we have a very good working relationship with them. So their assessment was that, we were dealing with a 34-year-old guy that was previously healthy, 4 weeks of constitutional symptoms, blah, 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 that he examined like somebody with cardiogenic shock, and that our bedside echo, which I showed in my pictures of, showed what they think was an LV thrombus. But they also thought that the posterior mitral valve leaflet was quite thickened. This with his associated elevated inflammatory markers. I think his CRP was 250. The overall clinical picture was certainly concerning for mitral valve infective endocarditis at this point. And the shock was certainly predominantly cardiogenic in nature. And this is where POCUS really helped us a lot, because within a span of coming through the door, within an hour, I had a cardiologist who was keenly interested in what I had to say because he looked at my images. And then at our site, this is not something that really should stay, and so we could make arrangements for a transfer. And sure enough, the patient was accepted into the CCU at the University Hospital, and they continued with the same diagnosis. Patient ended up on non-invasive ventilation as well as vasopressor support, which of course in the context of a mitral regurg does become a little bit difficult because it can make things worse. But his mean arterial pressure was such that I don't think there was much choice. So the chest X-ray was consistent with pulmonary edema at this point, and broad spectrum antibiotics was continued. I believe it was ceftriaxone and vancomycin at that time. Cardiac surgery was immediately also told about this patient. They came around and said, well, let's see how things go if this patient can't be weaned off his vasopressors, or if he worsens, we'll consider a surgery. Otherwise, let's see if we can find a TEE or get the patient stable enough for a TEE to look at that valve properly. So at this time, cultures and everything was pending. Unfortunately, the patient didn't really do as well as what they were hoping for. And so with this moderate MR with unclear etiology, the patient didn't resolve, the symptoms didn't resolve, and unfortunately his non-invasive ventilation didn't have the effect that we were hoping for, or that they were hoping for, and nor were they able to get the vasopressors down. So the very next day, the plan changed. The patient was actually taken to the OR, given his ongoing respiratory failure and cardiogenic shock. This time, the diagnosis was still believed to be infective endocarditis. So the patient underwent a mitral valve replacement. And the interesting intraoperative findings were as follows. They thought that the posterior valve was actually prolapsed, and that when they exposed the left ventricle, they found this mass that was kind of white and irregularly shaped, mobile, about 2 by 2 centimeters in size. It was lodged between the left ventricle muscle, and sounded like it was sort of within the mesh of the chordae tendineae. So it's possible that it was perhaps putting strain on the chordae, making the anterior valve relative, or the posterior prolapse relative to shortening of the chordae of the anterior leaflet is what I'm wondering. But anyway, they were able to remove this mass fairly easily, and it was all sent for pathology and cultures. If you're looking for more echo pictures, I'm sorry, I'm gonna disappoint you, but this is sort of 50-50. We had some echo stuff already, and I like to continue with this case to tell you what it was in the end. Infectious diseases, of course, was involved, and at this time, post-surgery, the patient's blood cultures remained negative, except for one coagulase negative culture that came back, which was thought to be a contaminant, probably. They ascribed this fact to amoxiclav that the patient had a week prior from his family physician with sort of similar constitutional symptoms. So the diagnosis didn't really change yet. So ceftriaxone and vancomycin was continued for a planned 6-week duration, with continued follow-up by infectious diseases. They did recognize in their notes that a non-infectious etiology may have to be considered in this particular case, and they certainly initiated that workup. And I must say that they did a very, very complete workup. They sent serologies for Bartonella, Brucella, Coxiella, tularemia, all of those things, and everything came back negative. So the indolent organisms were not present, which we really thought initially was going to be the case. So merantic endocarditis also came up. The patient had a positive ANA, but it's one of those 1 in 80 titer, neither here nor there, no other symptoms. And so rheumatology did see the patient and had a very low suspicion for autoimmune disease. And given that the fevers and everything resolved after his initial antibiotics, they felt that it's probably an infectious etiology. during their consult, they did notice, though, that at a certain point in this patient's hospitalization, he had positive blasts of approximately 2%. So not super high. And hematology saw the patient as well and weren't too concerned, thought that, this 2% blast probably represented a severe form of a left shift, and that what we were seeing was more of a leukemoid reaction due to infection, and that their suspicion of acute leukemia was rather low. So patient made a good recovery, was discharged from hospital and followed up with infectious diseases on an outpatient basis. The final diagnosis finally came back from histology, and it showed firstly that the valve had fibromyxoid valvular degeneration. And I don't know what to make of that, because this was a very young chap. He's in his 30s. So to have that sounds a bit strange, but either way, that's one of the things. But interestingly, no vegetations and also no infiltrates of any other sort. The left ventricular mass that we saw so beautifully turned out not to be a vegetation at all, but just thrombus. So this guy had a spontaneous LV thrombus for some reason. So during ID follow-up, they thought that this was probably not in keeping then with infective endocarditis, but that there was a spontaneous thrombus, and that a further workup is probably needed to try and figure out why a young male patient has this hypercoagulability out of the blue. So at that point, antibiotics were discontinued, and the patient continued to follow up on an outpatient basis with cardiology and was seemingly doing quite well until he wasn't. So a few months after this whole incident, he became acutely unwell again. He went to his local emergency room, and it was noted that he had fevers again, that he had headache, he had severe nausea, blurry vision, he had decreased appetite, he had a new cough with associated shortness of breath, some chest pain with heaviness on his chest, and just really felt worse every single day, and decided to go to his emergency room. It should be noted that his examination there was not really indicative of heart failure, and that the particular physician there was trained in point of care ultrasound as well, and mentioned in their note, which I didn't put in the presentation here, but that the LV and such looked normal to them. So the patient continued to go through the investigation mill, and this is what they found on that particular admission: white cell count of 327. Platelet counts were very low, and so was the hemoglobin. The differential showed 86% blasts at this time. So parameters suddenly changed, and patient ended up coming back to the city, and was admitted at the university hospital, and was looked after essentially by hematology alongside our ICU colleagues at the university hospital. This is more or less what they saw on the slide. Now, I'm not a hemopathologist, but those big, white cells with a fairly disorganized nucleus that is just taking over, those are the blasts, and so certainly things were not looking normal for this patient. He was ultimately diagnosed with a mixed phenotype B and myeloid AML, which was complicated at this time by pulmonary and CNS leukostasis, with that white cell count being so high and 86% blasts. This guy was admitted to the ICU for leukapheresis, and then started on his induction chemotherapy, which started on October the 20th. So it would appear that what I saw a few months prior in the form of that initial LV thrombus actually represented a hypercoagulable state from a hematological malignancy that was brewing along. and was waiting for, I guess, the blast to sort of spill over from the bone marrow at that time. So I thought this was really an interesting case, and that's why I called it, heart fever heralding real badness a few months later. So I thought I'd share this case with you and just again highlight how point of care ultrasound led to appropriate management, accelerated appropriate management, and advancement of the patient through the system to at least take care of his initial issue. I still think that this LV thrombus, impeded the mechanism of the mitral valve, and I think that's how he ended up with this moderate to severe mitral regurg and heart failure as a result.
I don't know how you'd manage the case differently. It sounds like it was kind of a cliffhanger before he came back in, because I felt like you were going to get an answer before he was discharged, but it sounds like it just wasn't really answerable per se.
Yeah, unfortunately not. There was no indication other than that blip, his blast count of 2% earlier, which disappeared again, I should say. It didn't persist. And given the fact that he had a systemic infection and was severely ill, it's not uncommon then to have certain cytopenias in that, and I think it was easy to explain all of his counts on account of the working diagnosis at that time.
Mm-hmm.
I did discuss this case a little bit with one of our hematology critical care colleagues, and one of the questions that she brought forward was, is the pathology available? Was there an infiltrate in the heart valve? So by the sounds of it, that can happen, but that certainly was not the case for him. I think it was just a hypercoagulable state, LV thrombus, spontaneously, that messed up the mechanism of the mitral valve.
Alberto, you have a question?
Yeah, no, the question to me related to LV thrombus is that, as you pointed out in your images, this patient had no regional motion anomalies. There was no significant LV dysfunction. And so the probability of having an LV thrombus is extremely, I would expect that the other thrombophilic manifestation, but not an LV thrombo. Usually LV thrombi, they need some anatomical substrate.
Mm-hmm.
And that's, to me, is what I don't really, it's fascinating, because again, is that I would expect an LA thrombus, sure. I would expect something else, some DVTs, but not an LV thrombo with that left ventricle. That's why I do think that there must be something anatomical that it was, again, they operated on it. It's very strange. And the other question is that you mentioned the consult said this guy needs a follow-up with the hematology. Was he follow-up appropriately by the hematology service in terms of a thrombophilic disorder? Because this guy, I assume, was referred to a thrombophilia clinic.
Yeah, he was. And I don't think that he actually saw anyone for that. This patient was certainly appropriately followed by infectious diseases as well as cardiology. So cardiology, felt that for his valve, because it was tissue valve, he wouldn't require long-term anticoagulation, but left it up to hematology. So by the looks of it, I don't think he actually made it to them for a hypercoagulable workup before all of this happened, or when until his leukemia was diagnosed, which of course was the reason for it. I don't think he was lost to follow-up. I think it was all appropriately followed. And it just so happens that in the time before he got to see anyone, he got acutely ill again.
Okay, we have a question here from Vince. Dr. Lau here.
Hey, Leon, great case. Before he went for his cardiac surgery, did he get a cath?
No, he didn't. So the interventional cardiologists were involved in his case, and they looked at all the imaging. And at that time, he also had a comprehensive TTE, and they felt that it wasn't going to add much, and that he was a bit unstable. And so they elected not to do it.
The only reason why we mentioned is, I know that the echo is read as normal, but we were just looking at that anterior wall in the two chamber that you had. It looked a little bit down. So I was just asking whether or not there was an LV aneurysm or something found, like a pseudoaneurysm or something like that, where the LV thrombus formed, or if there was any evidence of LV non-compaction. Just because, again, as Alberto mentioned, it's very rare if you're going to form a thrombus, it's probably not going to be the LV cavity. unless you have associated other stuff. So it's just very odd, and it's very sad for this gentleman. And I would wonder whether or not he had something else going on that again, like, not that there would be anything to do. And it sounds like a few weeks later his AML probably, I'm guessing, but I would imagine that probably has more of a marker on his mortality than anything that was found so far, right? You know what I mean? So
yeah, I think those are all very good points, and something doesn't happen until it does. I don't know how to explain it otherwise. I don't know if this clot formed elsewhere and got entangled in the chordae or something. Because if you read the intra-op note, they mentioned that it was really very easy to peel away from the LV muscle, and that there's no macroscopic description of anything that they saw anatomically that was problematic. I will say this to this patient, because he went on to chemotherapy, he's had follow-up TTEs, and there's again no mention of a LV wall motion abnormality or non-compaction or anything like that.
Interesting. Okay, well, we got to move on here, just sake of time. We got Dr. Goffey waiting in the wings here. So why don't we get Alberto on?
And thanks, everyone. It's a pleasure. It's very excited about this joining this group, and it's I think this is a step forward toward really making this more Canadian and having great opportunity for collaboration and also for learning from each other. So as I mentioned, is that very different from Leon, is that more than a case, I'm going to sort of talk about lung ultrasound and RDS. And the reason is because you may be aware that a few months ago, the Blue Journal published a new global definition of RDS where lung ultrasound made it through. And so what I wanted to do, I wanted to show a little bit how you can use lung ultrasound in the diagnosis of RDS and where we are nowadays, and a little bit of potential use in the management of patients with severe respiratory failure. And I see Vincent there, so of course we're going to talk about published studies as well. So this is my disclosure. I'm fully biased, as you all know, is that this is my daughter, that she was already scanning my wife when she was less than 2 years old. So we definitely use ultrasound maybe too much in our family. Okay. So RDS, you all familiar with the Auburn definition, and this is the conceptual model, right? It's increased lung weight, loss, right, the lung tissue. For the one that are familiar with lung ultrasound, it's perfect. That's what we see with lung ultrasound, right? That's that we see increased lung density, and we are very good at detecting loss of aeration. Despite that, in 2012, only CT and chest X-ray made it to the definition. That was 12 years ago. I was not ready for prime time, I think, ultrasound. So thinking about lung ultrasound, again, you can use it in the diagnosis and monitor the response to our treatment. So let's start with the diagnosis. This is a beautiful study that started a little bit the discussion around the use of lung ultrasound for RDS definition. So Beatrice Riviello is an intensivist from Boston, but she spent a lot of time in Kigali. And back in 2014-15, in Rwanda, the incidence of RDS was 0. And the reason it was 0 is because they didn't have available blood gas analysis. And that's why it was impossible for them to actually fulfill the Berlin criteria. So criteria that we consider very broad, the Berlin definition, were actually not applicable worldwide. And that's why Beth introduced the use of lung ultrasound, the SPFO2 ratio, and removed the PEEP criteria for the Kigali modification of the definition. And what she showed is that by using this Kigali modification, she was able to identify a very sick patient with a significant mortality in this cohort. So again, in terms of content validity, definitely something that I think is important. If you can differentiate a group of patients that are sicker than the other, it's very important for me. The group from Marco Schultz from the Netherlands, a couple of years after, they try to validate the Kigali modification and the redefinition in their setting. So it's similar to North America, I must say, so high resource ICU. And what they found is not unsurprisingly, is that if you apply the Kigali modification, so no PEEP, SPFOC ratio, and lung ultrasound with a very, very broad criteria, essentially bilateral B lines, you're going to have a lot of false positives. So a lot of patients that they fulfill the Kigali modification, but they don't really have ARDS. And that's the tension, right? What do you want to be here? Do you want to be sensitive or specific? In this case, they clearly show that we are not going to be as specific as maybe we want to be in certain situation, but maybe there is a benefit in this as well. And we can discuss maybe in the discussion about what we want from the definition of RDS. The question for me is, because we're talking about ultrasound, is that, okay, this is non-specific, and that's one of the theme of lung ultrasound. So we know the lung ultrasound is very sensitive and non-specific, especially B lines. Can we increase the differential, narrow this differential diagnosis and increase specificity? But one thing we can do is that integration in a clinical context. If I thinking about the case that Leon presented, that if the patient has fever, there was an acute insult, a trauma, pancreatitis, the probability that this is actually, or the patient is young, that increase the probability for RDS versus non-RDS is significant. At the same time, we do know that patients with heart failure, they also develop RDS. And that's why the old definition, the ACC definition with the PEEP, with the wedge pressure of 18 was removed, right? Because we were not including heart failure patient with RDS in the definition. We can also do, again, this is not just lung ultrasound, we are critical care ultrasound specialists, I think. And that's why you can actually add other application. And this is, for example, a study from the Mayo Clinic, when they added lung ultrasound and cardiac. And they showed that there was some improvement in their ability to differentiate cardiogenic versus non-cardiogenic specific context, for example, ARDS. But again, my problem in all of this is that you're going to see patient with ARDS and with heart failure. And so if I have a patient with ejection fraction of 15% at baseline and comes with ARDS, I will not be able to differentiate this based on simply this algorithm. In the past few years, the attention has really moved to this additional ultrasound findings, and I'm going to show you something. This is actually not a recent study. It was in 2008, small group, but what Roberto Coppetti did is that they took a priori a group of patients with known RDS and a group of patients with the non-cardiogenic pulmonary edema, and they tried to identify characteristics that were differentiating them. And again, for the one that they are familiar with lung ultrasound, you immediately see that this is not a normal pleural line. You see how it's thick. And again, I don't know if you can really call it thick, but it looks thicker. There are irregularities, it looks interrupted, and there are definitely presence of abnormalities of the pleural line. The other thing is that think about the pathophysiology of RDS versus cardiogenic pulmonary edema. In cardiogenic pulmonary edema, it's hydrostatic, the mechanism, it's starving. And so there's no way that you're going to find normal areas beside abnormal areas in non-dependent zone, for example, or in a non-dependent zone, a lot of B lines, and then no B lines in a dependent zone of the chest, because this goes against the pathophysiology of hydrostatic pulmonary edema. And that's sort of where we are going through, right? By looking at this characteristic, the distribution of the lesions and these apparent pleural abnormalities, we may be able to increase the specificity for this patient. Recently, a group from the Netherlands, again, sort of the same group that has been doing a lot of work on lung ultrasound, they tested the Coppetti's hypothesis as well. And what they did is that two steps, right? Is that patient with respiratory failure, B lines. If there are no B lines, they look for this posterolateral consolidation and prorefusion. And if the patient had some posterior lesion, maybe just pneumonia without RDS, but if the patient has B lines, and the B lines are bilateral with this pleural abnormality that I show you, much more consistent with non-cardiogenic pulmonary edema. So from a physics perspective, why do we see this pleural abnormalities? There's a lot of work being done in the past 3 years, but this is one of the hypotheses. And this is also the hypothesis about the B-line generation, right? Is that we have acoustic channels in our lung that are normally present, that are interstitial, like the interlobar receptor, for example, okay? So the interlobar receptor, they act as channels for the ultrasound to enter, and that's why we do see those short vertical artifacts that we do see in normal patients. But if your patient has a significant increase in the thickness of the interstitial, or the content of water, for example, like in this case on the left, cardiogenic pulmonary edema, you will have the appearance of the B-lines. And because this is interstitial at the beginning, would be spaced, and it would be not affecting the pleural line. If I have an inflammatory process that now is involving the alveoli in a non-homogeneous way, the channels, they change conformation. And that's what leads to this abnormal appearance of the pleural line. More recently, Mary Smith, from the group of Marco Schulz and Uwe Boss, that is going to be at the CCCF actually this year. What they did is that they perform an observational study. They enroll consecutive patients with respiratory failure coming to the ICU, and they analyzed 453 patients. 324 in a derivation cohort from Amsterdam, and 129 in the validation cohort from Maastricht. And what they found is that if you combine B-line score, so the severity of the B-lines, this B1 part, the B2 part, and then consolidation on the right and the left, plus anterior presence of pleural line abnormalities, this can lead you to a score they call the RDS lung ultrasound score that has a quite good diagnostic accuracy for RDS versus a reference standard that was a quite well-structured, I might say, reference standard assessment of RDS, because of course we don't have a troponin for the RDS, and so as we know there is a problem in terms of what we define RDS. But I think they did a good job in trying to, as much as possible, to standardize this. Remember the content validity, right? Is that so? Is this important? And why do we need to do lung ultrasound? We already have chest X-ray. So first of all, think about resources where chest X-ray is not available. The other possibility is instead maybe you're going to identify patients that they will not really frame and name as RDS. Like for example, in this cohort, this is a group from Singapore, but what they did is that they trained the RTs, and every single patient admitted to their unit gets lung ultrasound. And then they retrospectively look at their data. And what they found out is that there is out to 295 patients that with the RDS sort of definition, 79, they would not have qualified for RDS diagnosis based on chest X-ray criteria. And when they look at their mortality, it was not very different, maybe even a little bit higher, again, non-significant. But the point is that either two possibility, as a possibility is that what really matters is the PF ratio is not really the bilateral infiltrate, but that's another aspect. Or if we do believe that there is an importance of imaging in this patient, then RDS would have missed 79 in this the burden definition of patient that they would have the same mortality of the burden definition patients. And again, as a non-English speaking person, I realized very early when I moved to Canada that naming disease and people correctly changed the approach that we have. If I'm telling during rounds, this patient has RDS, everyone is much more attentive, for sure. And that's what led this, right? That is what led to the new global definition, where now we have lung ultrasound included. And there are some caveats. There's a lot of work to be done at the point that the idea of this new global definition is really a roadmap more than a true change. Lung ultrasound correlate very well with severity, is that the more B lines, worse PF ratio. Can also tell us information related to the characteristics, morphology, right? Is that if you look at the chest X-ray, there's no chance that you can tell if this patient has a more diffuse involvement or only posterior involvement. But if you do lung ultrasound, you can immediately identify in the patient that they have a diffuse involvement or have the involvement in the dependent regions, in like focal versus non-focal RDS. Can also help you identifying, okay, this patient has respiratory failure RDS, but then there are information that sometimes they are so sick they cannot go for scan. And I don't know, maybe I'm gonna stop with the diagnosis and I'm gonna monitor, but if you, for time's sake, but if you, for the people in the audience, is if you see this image, so bad RDS, patient is prone, you do lung ultrasound, you see this. What are you concerned for? Any idea? What do you see here, guys? So this patient has a big lung consolidation, of course. You can see here that there is complete appartition of the lung at the point that it doesn't really differentiate very well from the liver. This is the diaphragm, dynamic bronchogram. What is this?
We had someone here, Alberto, say in a room here, because there's 8 or so in the room, suggest maybe there's an abscess there.
Very good. This is a necrotizing pneumonia, right? With lung destruction and lung abscess. Excellent. And there was no chance on just simple chest X-ray to have identified this, and the patient was too sick to go. Then again, that can help you in terms of thinking about antimicrobial coverage, duration antibiotics, right? Is that there are a lot of things that they can tell you in terms of information. And this is sort of my idea, right? Is that ultrasound, of course, can just tell me what I know already. It corroborate my support, my pretest hypothesis. Sometimes they can also mislead you. Okay, be careful, because I had patients where the ultrasound led to misinterpretation of the findings. Sometimes we do see things that, okay, great, it's an incidental finding, not really changing my management. But there are situations where actually, and a lot of them, up to 30% of literature, that is actually changing my diagnostic or therapeutic approach. Brian, where we are in terms of time? I think I'm going to stop here. I just want to show you one. Yep. I'm just going to show you two single images, if it's okay with you, some monitoring.
Yeah, please do.
This is just because it's historical. This is what I did this ultrasound when I was a fellow back in 2012, I think. So it's 12 years ago. But this is the day that I understood the concept of tidal recruitment. So if you can see here, this patient was on 25 PEEP, and I was scanning the patient. You see that she was going during a tidal breath from consolidation to B pattern, consolidation to B pattern. On 25 PEEP, this patient was having opening and closing of the dependent zone. And to be honest, is that I understood the idea, the concept, but I'm a very visual person. I didn't really grasp it until this day. And since then, I've been using this in certain circumstances. This is a near drowning that I took care 1 year ago. Patient was profoundly hypoxemic, was cardiac arrest, not an ECMO candidate. And this was this big, large consolidation on the right base. So I just did a very simple sustained inflation. Look at what happened when I increased the PEEP just temporarily to 30. Now.
Wow.
The patient completely opened up and recruited the lung. And I had plenty cases. This is another guy, I'm going to finish with this one, where you can see here doing sustained inflation. And I'm just going to show you at higher PEEP that the lung stayed open. And this is chest X-ray pre and post recruitment.
Wow.
This is 2 hours apart. So again, there are things that you can do. And I'm going to quickly go through this. You can actually monitor the recruitment during prone positioning. And again, there are some studies now sort of suggesting you can predict the response, the oxygenation response to prone positioning by looking at central characteristics of the lung ultrasound. you can monitor this patient during ECMO. What you can't yet do reliably is this part here, right? Is the overdistension, the hyperinflation.
Yes.
And Martin Girard, there is an intensivist from Montreal, has published something on using speckle tracking in lung ultrasound. Pre-pandemic, I was working with Maurizio Cereda, that is now in Boston, when we did a couple of experiments to try to see if we can detect overdistension by looking at the oscillatory pattern during lung pulse. And so I think again, right now it's for research, but I do think that it's going to happen, that we'll be able to, with AI especially, look at the lung ultrasound pattern, not just for recruitment, but also for overdistension. And I'm going to finish here.
Okay, that's awesome. That was a fantastic discussion, Alberto. I think it gives a lot of perspective on how ultrasound can be used in kind of in more conventional ways with ARDS, as I think many of us have found in our own practices.
Alberto, that was great. I've definitely seen times where the X-ray is completely normal, and PF ratios are low. We intubate the patient, and the only way we get the ARDS assessment is by CT, because they're clean chest X-ray, so therefore we get a CTPE, no PE. But it's like, but in the intervening time, Brian or I or the fellows have been trained to do the lung ultrasound ahead of time, and in fact, the lung ultrasound told the story more than anything else, and the CT was just confirmatory. So yes, I think that's great. Yeah. And then the second comment I had was, there's lots of times where, you know, we have the RT in the room, we're ultrasounding, and we just ask them to put the peeps up. Lots of times we get more aerated lung, and we know we're doing better job, especially, I mean, we're here in Alberta. I'm not sure in Toronto it's the same thing, but the BMIs are not low here. So definitely peeps of 18, 20 might not be enough. And yeah. So the dynamic response, because again, a CT won't show that, right? You can't send them down, 1 second and then 20 minutes later after recruitment maneuver, send them down. This is the only way to get it. So I think it's great what you've just presented. So yeah.
Thanks, Vince.
Awesome. Okay, I'm gonna for the last 10 minutes here, I'm going to go through a case that I had that I wanted to share because it was very challenging for me to work through. I was on with a couple of residents here, and I was challenged by this code blue call to the ward. Can everybody can see and hear this case, Mr. AL? Perfect. Okay. So, 60-year-old male with hematuria who was running continuous bladder irrigation on the ward. And basically he had an abrupt drop in his level of consciousness. We were just told that, there was potentially a cardiac arrest. He actually had an arrested, but he was very hypotensive. His pressure was about 70 systolic. He was in respiratory failure. We got there and, it was clear we needed to have this guy get intubated, but his pressure was frankly too low. I think he would have arrested if we tried. And he was awake enough that he would need something to calm him for, or at least sedate, induce him for intubation. So in the meantime, we established some IV access, more IV access, and gave him some push dose pressors. Initially phenylephrine, I did nothing. I moved on with some IV fluids and epinephrine, 10 mics per mil, kind of 1 mils, 2 mils, 5 mils. Nothing happened at this point. His blood pressure remained 65, 70, kind of didn't change at all. And so at this point, this patient had a previous cystoscope a few days prior, and there was a clot in the bladder. And so we thought, well, maybe this is just, this is some ongoing bleeding, and we just haven't recognized it. And we looked at the Foley bag. Indeed, there was blood in the Foley bag. So we thought, well, probably needs to either go to an OR or have the bleeding identified. So in the meantime, we started a mass emergency protocol just based on the suspicion and the refractory hypotension, and he was pretty pale. So we started that. And then, so unfortunately, he rapidly deteriorated, extremely rapidly. He basically went bradycardic and then arrested. He arrested for 20 minutes, not a single time did we get the pulse back. And it was pretty challenging arrest. His anatomy was, because of some ankylosing spondylitis, quite challenging. There was really no transthoracic window. So we actually, at a 20-minute mark, we actually truthfully called it. We said probably is not going to recover. He's not recovered a single rhythm during this time, nor a single pulse. Perhaps we should stop. So at the 20-minute mark, we were kind of on the cusp of stopping, and lo and behold, he actually had a pulse. Surprise, surprise. So at this point, he was on a Lucas device for most of that time. So he had automated CPR for most of that time. So we decided to put TE probe down, of course, in the process of bringing him to ICU. That's the Lucas device for those who are unfamiliar. This is not the patient. This is just a stock photo, kind of how this device looks. But it can be pretty effective if placed well. But oh no, there's actually handholds with Velcro. That's what that is. Yeah, so you can actually Velcro the hands. That way they stay away from the sides of the bed. Yeah, so they don't flop around. But so Lucas is applied. So you can imagine it's quite hard to echo a patient like this. So the first thing we did here, this is just for those who are maybe unfamiliar with TE. This is not really a TE case per se, but I'll get to why it kind of matters in this case in particular. So basically, this is a mid-esophageal 4-chamber view. Probe comes down, rather it shoots from behind the heart and gives us this fantastic, basically an inverse apical 4-chamber view: left atrium, left ventricle, right atrium, right ventricle. So really nice view here. This is not the patient's heart. I'll show you the patient's heart next. This is the patient's heart here. And in fact, it was quite reassuring. In fact, almost like too reassuring. Like obviously the heart here is not the problem. And it also made me wonder too, if that we weren't detecting a pulse, was it just because he had profound either vasoplegia or just profound volume loss? So heart function was actually normal. And again, very reassuring. We looked at the valves. Valves were all normal, really no cardiac issues whatsoever. So I had a question here. For the sake of time, I'm going to move on. So moved on to just a mid-esophageal long axis view, which is very much like a personal long axis view. Okay, so that's his heart there, left atrium, left ventricle, aortic valve. Again, very, very normal. Really nothing to see here. Just help instructive at this point. And he settled out, actually, came to ICU and really was on next to nothing for vasopressors, which we thought was quite surprising. He had a couple of units of blood, had some 2 liters of crystalloid in the course of this. We brought him down to ICU and we stuck in a big cordis in the subclavian just for access. And we thought, in talking with urology, let's get a CT, CTA, and basically was in the process of doing that. I will mention that as part of that TE, we recognize that he's profoundly hypoxic. And this is just an example this is just a study looking at how ultrasound TE can be used to examine the lungs. You can see different planes here, either at 0 degrees or 90 degrees. The probe can be rotated to examine different lung zones, to look for things like deaeration or collapse or even pleural effusions or whatever's in the pleural space. So if you're in there with the TE probe, it's very easy to add this on as kind of a TE LUS or the kind of TLUS or TELUS exam in terms of lung ultrasound. So we actually have used this for a lot of patients because for a lot of folks, we just don't have that information because of whatever reason, because of their acuity. So the next thing we did for this patient was, obviously here we're at 82 degrees. I just started to take a look around. This is on the left side of the thorax. Obviously a big pleural effusion, some collapse there. And looking at more of a transverse view, you can see again, this lung is all collapsed. There's a pretty sizable pleural effusion, but this is only one section of the chest. So again, this is in a transverse view, almost like kind of a CT-based view, kind of at the foot of the bed, but of the left thorax. We can see here, again, just a lot of fluid, a lot of collapse. In fact, both sides look the same. This is on the right. So a lot of pleural fluid, which I must say for the case was a little bit odd because the patient actually was pretty well before this presenting with hematuria, actually has few comorbidities. So now he's got bilateral effusions. So at this part, this guy's really hypoxic, and we thought, well, for this guy to go down for a CT, CTA, we can't send him down there on 100% oxygen because that would be really bad. So we're talking about draining his chest. However, in the meantime, he has a sudden deterioration in his blood pressure and we can't ventilate him. So at this point in time, I have not left the room for a couple of hours now, and it's getting pretty long in the day, long in the tooth. So he's on the cusp of rearrest now, and I simply can't get air into the guy. His sats are 84, 80%. It's just getting really bad. And at this point, I have a suspicion that yes, this seems like it's from the lungs, but he's also got this, CBI running, his bladder irrigation. And my question became, do we have a problem here? And, as one of my surgical colleagues always said, just look where the surgeon was. And so there was quite a bit of fluid under the diaphragm. And so we thought, well, that's also not expected in this patient who's previously well. So this patient now has seemingly massive ascites, massive bilateral effusions. Maybe what our problem here is, and maybe I can ask the gang here, if you scan this QR code, you can propose in short answer what you think the problem is. So here we have a suggestion that maybe it's a hole and there's third spacing. So our really just intraperitoneal spacing, I guess you'd say, versus third spacing. Intrathoracic, yeah, bladder rupture, yeah. So that's in fact what we thought this was. So we promptly, the abdomen actually was initially soft, but we decided to urgently do a paracentesis. So I stuck in a needle at the bedside fairly urgently. This is what I got out of there. So we inserted bilateral lower drains. We thought the Foley had ruptured. The bladder pressure, although you'd argue this is actually a true abdominal pressure, was 28 after we took off 1.5 liters. After sticking in bilateral chest tubes, it was the same fluid. So then we did a bronch just because of the parenchymal collapse, and then later went to OR for repair. So we had to really buff this guy up to get surgery because he was pretty rough. But basically, a very strange story. I don't know initially on the ward if this was just the sentinel bleed and then was in the process of rupturing, because his belly was initially soft, and that was examining with surgery. But things really went downhill from there. But certainly a case where you look at the lungs and think, well, is this the problem? But then, of course, with the change in ventilation capacity, I thought, well, actually, maybe this is a bit lower down in the abdomen. So he underwent repair, and it was much more stable thereafter. So as I mentioned, look where the surgeon's been, and multiple illness is an important concept. But that's it for now. If there's any questions at all?
Did you stop the I assume that when you transfer the patient to the ICU, you stop the CBI.
We did not actually, because the CBI was running, and there was no, we talked to urology, and there was actually quite a bit of clot. So we were a little worried that he would have truly clotted off the bladder. So that was what our concern was. But once we had figured out that there was fluid in the belly, we actually reversed the CBI. So we actually started just not put fluid in and just suck it all out.
I had a patient once that ruptured and she rested on the floor, and she had a one-way valve effect. So there was a clot, there was occluding the catheter, and so she ruptured and she rested similarly. Yeah,
it's nasty. I mean, I think that the urology team now is obviously much more aware of this problem since, but certainly when this happened, like I said, at first the guy's belly was soft, the CBI was running fine, there was some blood in the bag, yes, but we didn't have a high suspicion of this being primarily a bladder issue, but over time it became pretty obvious that that's what it was. Anyways, I'll close it off there. Thanks everyone for coming. I think that was a very exciting, good discussion for a first Canadian-wide ultrasound round. So thank you everyone for coming, and I look forward to any suggestions that anyone has on format for the next one, which will be in probably 3 to 4 months.